Med History.
Brain lobotomy was developed in 1935 by Portuguese psychiatrist and neurosurgeon Egas Muniz. In 1935, at a conference, he heard a report on the consequences of damage to the prefrontal zone in chimpanzees. Although the focus of this report was on the learning difficulties associated with damage to the frontal lobes, Manish was particularly interested in the fact that one monkey became more calm and obedient after surgery. He hypothesized that the intersection of nerve fibers in the frontal lobe could help in the treatment of mental disorders, in particular schizophrenia, the nature of which was still very vague. Manish believed that the procedure was indicated for patients in serious condition or those whom aggressiveness made socially dangerous. Manish performed his first operation in 1936. He called it a lobotomy. A loop was inserted into the brain with the help of a guide, and the white matter of the neuronal connections connecting the frontal lobes with other parts of the brain was cut through with rotational movements. Manish performed about 100 such operations and observed the patients. He liked the results, and in 1936, the Portuguese published the results of the surgical treatment of 20 of his first patients. 7 of them recovered, 7 improved, and 6 did not show any positive dynamics. Egas Manish was awarded the Nobel Prize in Physiology or Medicine in 1949 for discovering the therapeutic effects of lobotomy in certain mental illnesses. After the Manish Prize was awarded, lobotomy became more widely used. In the late 1940s, psychiatrists discovered that lobotomy studies were conducted without proper methodology, which led to operations on patients with different diagnoses using different techniques. In the 1950s, more thorough research showed that lobotomy can cause various problems such as seizures, weight gain, loss of coordination, and others. Standard tests of memory and intelligence usually showed no deterioration, but complex mental processes could be disrupted. Patients could retain some abilities, but experience changes in behavior and emotions, and their criticism of their own behavior decreased. In addition, they might have problems with targeted actions and were more likely to be in a state of indifference or euphoria. They could have emotional breakdowns, impulsivity, and unreasonable ambitions. The decline of lobotomy began in the 1950s, when serious neurological complications after the operation became apparent. Lobotomy has been legally prohibited in many countries due to the low effectiveness of the operation and the greater danger compared to new treatments such as antipsychotics. Although Manish received the Nobel Prize for the development of the lobotomy method, but in the sad history of this operation, the name of another American scientist, Walter Freeman, is more well known. In December 1942, Freeman and a colleague, neurosurgeon James Watts, published a report on 136 lobotomies on psychiatric patients. 3 patients died on the operating table, and 8 more died shortly after surgery. 98 people had significant improvements due to surgery. However, not everything was so successful. For example, John F. Kennedy's younger sister, Rosemary, suffered from a lobotomy performed by Freeman and Watts. Her intelligence dropped to the level of a 2-year-old child. She forgot how to walk and control her hands. Rosemary was placed in a psychiatric hospital where she spent the rest of her life, dying at the age of 86. Despite the setbacks, Freeman continued to perform lobotomies and even tried to improve the methods of surgery. In the early 70s, lobotomy gradually fell out of use, although in some countries operations continued to be performed until the late 80s. For example, 32 lobotomies were performed in France from 1980 to 1986, 70 in Belgium during the same period, and about 15 operations were performed annually in the UK. Lobotomy was officially banned in 1950 for scientific reasons, not just ideological reasons. The main arguments were as follows: the lack of a clear theory of lobotomy, the lack of clear indications for surgery, and serious negative consequences for patients, including a frontal defect. We can say that lobotomy still had a certain potential. The work of the brain as a whole system is supported by a huge number of connections within it. These connections are responsible for the activity of the whole organism as a whole, for recognizing visual images, performing automatic movements, fine handwork, and so on. They are also responsible for the formation of mental disorders, and in order to combat these disorders, it is with connections in the brain that it is necessary to work first. The problem is that in terms of functional connections, the brain was a black box during the rapid development of psychosurgery in general, and lobotomy in particular. However, he remains one now. The irreparable consequences of a lobotomy like paralysis are not surprising, and are inevitable even in cases where it was not a tool that would be more suitable for a bartender than a doctor, but sterilized medical devices and the latest methods at that time. Therefore, the doctor who performed the lobotomy almost completely relied on luck. It is luck that explains why some patients actually received some benefit from the procedure. From the observed consequences, some experience could be learned to improve lobotomy, but this was not done. The method of surgery was radically changed only once, starting to use orbitoclast, and then the changes were by no means for the better. People continued to die and become disabled. Perhaps if lobotomy had lived to the end of the last and the beginning of this century, the situation would have been different. And with the improvement of surgical and neuroimaging methods, psychosurgery would actually have become a method of treatment, for example, for schizophrenia, for which there is still no cure. However, this did not happen, and it seems to be for the best. Lobotomy is an irreversible brain surgery that is performed to reduce mental symptoms in patients with severe mental disorders. Although this procedure helps some patients cope with severe symptoms such as aggression, depression, or schizophrenia, it can also cause serious side effects such as loss of cognitive functions, character changes, and memory impairment. Thus, lobotomy can be a last resort in extreme cases when other treatments do not bring results, and its use should be carefully considered and discussed with the patient and his family.